Hi, everyone. This is Carly Houchin from the Kansas Health Institute. We'll get started in just a few minutes here, right at noon, but wanted to let you know that our live stream has started and you should be able to see at this point our agenda for our meeting today on the screen. But again, we'll get started in just a few minutes. Thanks. Hi, everyone. This is Carly Houchin at Kansas Health Institute. We'll get started in just a couple of minutes here, but I see several people in the process of joining, so I want to make sure everyone knows our live stream has started and you should be able to see our agenda for our meeting today on the screen. Okay, I show 12 o'clock. Hello, everyone. This is Carly Houchin at KHI. So thank you all for joining our meeting of the Policy and Treatment Working Group here, I guess this afternoon now. We will get started with a few quick introductions in just a moment, but want to first see if I think Jenna from the Revisor's Office is ready to read us the statement on open meetings.
Yes, and good afternoon. I'm taking the place of Eileen this afternoon, but I also staff the same committees. And this is the meeting of the Special Committee on Mental Health Modernization and Working Group on Policy and Treatment. Due to health and safety concerns, members of the public are not in attendance at this meeting of the Special Committee on Mental Health Modernization and Reform Working Group on Policy and Treatment, but full access to this meeting is being conducted by medium of interactive communication, allowing members of the public without cost to listen to the meeting through use of live stream, audio broadcasting on the internet, and teleconference as available. This video can be accessed on the YouTube webpage by searching for the Kansas Health Institute or KHI live channel. The agenda and all documents for this meeting have been provided by the Kansas Health Institute. Additionally, a link to these documents has been provided in the comments section of the YouTube video previously referenced. Each member of the working group and staff shall state their name and title each time you begin speaking or voting so that you can be readily identified by remote listeners. All participants are required to ensure that microphones, phones, or other electronic devices are muted when not speaking, so the ability of remote listeners or observers to hear the proceedings is not unnecessarily impeded. Public comment will not be allowed at this meeting. During this meeting, the committee will not recess to a closed or executive meeting pursuant to KSA 754319 and amendments thereto, and each motion, if any, will be clearly stated before the working group votes, and the chairperson will announce the result of the final vote.
Okay, thank you, Jenna. So this is Carly Houchin again from KHI. Have a full agenda today, so to quickly overview that for us. As a reminder, this group is tasked with pulling together pieces of a strategic plan for modernizing the behavioral health system in our state. To that end, our primary topic in today's meeting will be special populations. That was one of the 3 topics assigned to this group by the special committee. And I would direct you to the meeting materials that were sent out and that are available in the link that Jenna described. The WG2 Crosswalk Agency document will be a helpful one to have open throughout our meeting today for reference, as that is where the prior recommendations on special populations from different groups are crosswalked. So we will get into the discussion of the special populations recommendations in just a moment. Following that, we will develop new recommendations related to that topic, new recommendations that hadn't been addressed in by previous groups. Before we do that, we will here in a moment quickly do some introductions of the working group members on the call. And then we will wrap up discussion of the treatment and recovery recommendations. So that was the topic of this group's last meeting. And as you'll recall, working group members received a Qualtrics link that gave scores to me for the recommendations we didn't have a chance to discuss in the meeting. So what we'll plan to do is review those results and make sure the average and consensus response is something the group is comfortable with. Before we jump into our agenda, I want to remind everyone of our meeting commitments. We're coming ready to discuss and compromise. We're going to work to keep remarks succinct and on topic. We're going to speak up when we have any quick clarifying questions, and we're going to work to start and end on time. So with that, I'd like to run through the working group members on the call here to make sure everyone knows who's on the line. So with that, I think the first member I'm seeing on the list is Gary.
This is Gary Hinault, Behavioral Health Director for Youth at KDATS.
Very good. Next, I'm seeing Wes.
Okay, this is Wes Cole, and I chair the Governor's Behavioral Health Services Planning Council.
Very good. And Lisa?
Lisa Southern, Executive Director at Compass Behavioral Health.
Deb?
Deb Stidham, representing the Kansas Association of Addiction Professionals.
Erin?
Erin George, member of the Johnson County Mental Health Advisory Board and person with lived experience.
Very good. Candace?
Candace Sinai, State Government Affairs for Cigna.
Kathy?
Kathy Bush, State Board of Education.
Next, I see Kelly.
Kelly Hansreed, Director of Medicaid and Children's Mental Health for DCF.
And Kelsey.
Hi, Kelsey Torres, Behavioral Health Consultant at KDHE.
See Rachel.
Hi, it's Rachel Marsh. My voice is a little out with Children's Alliance of Kansas. Bear with me, thank you.
Great, glad you could join us today, Rachel. Hope you get to feeling better. Rennie?
Rennie Schuler-McKinney, Advent Health Shawnee Mission, the Behavioral Health Service Line.
Sunny?
Hi, Sunny Mickle, Vice President of Government Community Relations for Blue Cross and Blue Shield of Kansas.
Very good. Any working group members who I missed running through that list there? Okay, not hearing any. The first item on our agenda is wrapping up some discussion related to the treatment and recovery recommendations from our last meeting. While I get that screen share ready, I will let the group know we have, I think, about 11 recommendations to get through still on this topic, which, if you look at our agenda, puts us at about 2 minutes per recommendation. So apologies in advance if this portion feels quick, but bear with us here, and we will overview these Qualtrics results as quickly as is productive. Okay. So you should see the treatment and recovery recommendation rubric meeting working document on my screen now. The first recommendation that the group scored via survey had to do with intensive outpatient services, and it received an average ease of implementation score of 4, as well as a potential for high impact average score of 7. I want to also flag for the group that there was a comment made in the survey that this recommendation might now be redundant with a new recommendation that the group drafted related to service arrays. So I want to put that on the screen here. The new recommendation that this group drafted at the end of our last meeting had to do with exploring options to expand the behavioral health service array available to individuals across the state, as you see here. So before we maybe discuss in detail either the scores for either of these recommendations, would like to pose the question to the group. Should these recommendations be combined in some way? Is one or the other more appropriate? Or is there a distinction that should be preserved?
This is Kelly Hans-Reed with DCF. It seems like they're redundant and they could be combined.
Okay, so hearing interest to combine those, I'm going to copy this one up to this first recommendation here. Kelly, would you care to weigh in? Is there one or the other recommendation language that seems more appropriate? Or is there a piece in the service array that we should be sure to capture in as a revision to the intensive outpatient service recommendation?
I don't really have any strong opinions.
This is Gary from KDEDS. I was thinking the part you just added there seems to be much broader and would be looking at more than just intensive outpatient services. So in that sense, it seems like it may fit better, the idea. I mean, we could put, like an example, intensive outpatient services and anything else people would like to put in there.
Okay, very good. Tidy up that language here in just a moment. But would like the group to weigh in on then how this recommendation is scored. So I guess we kept a larger part of this second recommendation, which scored a 5 and a 9. So let me make that update. But would ask the group with this combined and then slightly revised recommendation, how do these scores look to you? Any revisions, edits, or comments there?
This is Gary from KDEDS. I think the scoring's good.
Okay. Very good.
Deb Stidham, I agree.
Very good. Then I will move us along. We combined this one, so we'll skip over that. The next recommendation that we had scored via Qualtrics is the one that you're seeing on your screen here. Has to do with increasing the availability of flexible treatment options, both residential and outpatient, that allow children to stay with and participate in treatment with their parents, which also embrace a holistic and trauma-informed approach to treatment. So the average score for ease of implementation on the survey was a 5. The potential for high impact score was a 7. A few descriptive comments throughout this table here, as well as the comment as far as its contribution to modernization, that treatment should be made in the least restrictive environment and should start at the home. Any additions, corrections, or edits to how this one was handled via survey?
This is Gary from KDEDS. I don't have any edits.
Deb Stidham, I don't either.
Very good. Well, I'll move us along. If I'm going too fast at any point, please feel free to flag me down and we can move back at any point. Okay. This next recommendation that was scored via survey has to do with medication-assisted treatment. Before we get into discussion of how this was scored, a comment that was posed to the group is that there are a handful of recommendations related to expanding MAT or increasing availability of buprenorphine. So a question to the group, are you interested to combine any of these recommendations? So it would potentially be this one here, which kind of pretty high level says expand access and utilization of medication-assisted treatment. The comment on the survey had to do with the comment on the survey said that and maybe another one that could be combined was PE2 related to provider training. That's currently sorted in your prevention and education topic, but has to do with, I believe, training providers on medication-assisted treatment. And then a third recommendation that could be considered as related is increasing the number of buprenorphine waivered prescribers practicing in Kansas. So we'll pause there to get input from the group on how you'd like to handle these potentially related recommendations.
I think it makes sense to combine all of them, and particularly this recommendation around prescribers. It's part of expanding MAT.
Okay. So have added that language here. Does that change how the group would be interested to score this recommendation? So now is about not just expanding MAT, but also specifically that a piece of that work should be increasing the number of buprenorphine waivered prescribers. We have an ease of implementation score of 5 and a potential for high impact score of 4. Any comments, corrections to those average scores there?
Deb Stidham again. I guess I would advocate for a higher impact score. While it may not impact, a large percentage of Kansans, the impact for opioid use disorders and alcohol use disorders on that population is quite significant in terms of increasing outcomes. So the cost savings would be significant. The recidivism, et cetera.
Would you care to toss out a number for potential for high impact for the group to consider?
I'd say 7.
Okay, and any discussion from the group on that?
This is Gary from KDEDS. I felt that the impact score should be increased also. I'm okay with 7.
Very good. Any other discussion from the group on either the language changes we've made here or the changes to the score?
This is Andy with KDEDS, and I would suggest that we also include in the language of the recommendation MAT in jail settings. We might also want to consider whether or not we want to expand MAT within block grant services.
Okay, I've made note of some of those changes above. Any discussion from the group on those changes, or would that change how we would consider either the ease of implementation score or the potential for high impact?
This is Deb Stidham. I just would like to make a comment that from my perspective, in addition to the expansion of the service array, this particular recommendation is probably one of the single greatest things we can do to modernize the system for, in particular, the SUD population.
So Deb, this is Gary from KDEDS. Are you feeling that the impact should be higher than 7?
Well, I gets into my own passion about this topic, I guess. I was trying to be a little objective, but potentially, yeah.
Gary or Deb, if there's interest in scoring this higher for potential for high impact, feel free to toss out a number for the group to consider.
What do you think, Gary? 8 or 9?
Well, I wasn't quite at 7 when you said 7, but then when we add what we add to that, it changes it some for me. So I would be okay with 8.
Okay, let us look at the 8 for a second and see if there's any discussion or pushback there.
This is Kelly from DCF. I'm fine with the 8, but you know, if we're considering, like, obviously this is going to be a very high impact for the SUD people in the SUD population. But when I consider potential for high impact, I think of the population of Kansas. And, you know, that's kind of how I scored my other potential impacts. You know, when I look at other areas, you know, of course, on child welfare and children, you know, some of those other service areas, I would like to put 10 if I'm thinking about just child welfare, but I wasn't. I was thinking about the entire population of Kansas. But maybe I had that wrong. Maybe that wasn't the right way to think about the definition. So I guess I'm just concerned if we like continue to score everything. Like, Deb, this is your passion. That's great, you know. But that's just kind of what's going through my head. I'm fine with leaving it at 8, but I would be concerned if we went through every single one of the rest of them, thinking about like just our particular population that we in particular serve, and then thinking about if it's going to be a high impact for that particular small population, or maybe not small, I don't know.
This is Gary from KDEDS. I agree with what you're saying there, Kelly, but I also know that I think last week we did score some impact higher with the caveat, you know, placing the comment in there that as it has in this one, that it may not be a huge group. You know, it would have a huge impact on the folks that would be impacted, but maybe not in the sense of numbers of people in general in the state of Kansas.
This is Kelly from DC, if that makes sense. You know, high impact for a small population is different than high impact statewide or whatever.
Yeah, and I think if we note that, I think we're okay, but you know, maybe up for discussion too.
So this is Carly at KHI. I'll just jump in to add. So we have made that note, Kelly, here next to the question about, you know, will this benefit a large population? So we've captured that note here. And for the group, just in terms of process, I'll just remind you, or I guess maybe let you know, once we've gone through everything and scored it this first time, our subsequent meetings, we're going to be kind of looking at how that shaped out in terms of our priority list. And from there, we'll be able to pull out the things that should be highest priority, you know, maybe considering specific populations and making sure those necessary modernization changes are captured, and kind of going from there. So I guess what I'm saying, this is our first pass scoring, and if this doesn't sit exactly right whenever we do a review, there will be certainly an opportunity to make that change.
Yeah, so what I was thinking is how the data gets put together. So if there was like a spreadsheet and the only thing that goes on there is the 8 and not the additional, you know, little narrative, and someone does a a sort on that does go to that top priority when really there was additional information that went with that 8, I think is where maybe Kelly's thinking.
Yes, thank you for articulating it better than I could, Lisa.
Well, I'm working on spreadsheets today and doing sorting, so in my mind.
Well, I think that's a very good point. This is Gary from KDADS, Lisa, so thank you for bringing that up.
Yeah, okay. So we will plan to discuss this one further whenever we kind of come back and look at it in the universe of the other recommendations the group might be considering as highest priority. But I'll leave it as is for now, maybe just in the interest of time. Okay, so then this next recommendation here is the one that we've just added to the recommendation above. And the next recommendation has to do with presumptive approval of Medicaid. And again, would refer you here to that WG2 crosswalk agency document where this is listed. I think there's a note from KDADS in there that they've investigated this recommendation and it doesn't appear to be possible at this time. So with that, there were a couple of comments, I guess, to that effect from the survey. Is the group interested to, I think there's 3 options. Is the group interested to remove this recommendation because the agency's explored it and it is not a good option? Is the group interested to put this recommendation forward as is with kind of the continued request that we keep an eye out to see if this becomes possible? Or option 3, is the group interested to change the language of what the request is here to kind of urge the agency to take a different tack at it?
This is Andy Brown with KDADS. And Carly, I think this actually came up yesterday in one of the recommendations that work group made with regards to making sure that the EHR that the state hospitals were putting together was going to have kind of have the enrollment information available so that connected with KDHE's processes.
Mm-hmm. Yeah, thank you.
I
Thank you
don't
for that
remember
reminder.
what the wording was, but
yeah, I think the language there was about reinstatement of Medicaid eligibility. So yes, the other then important piece of information for the group to know is that a version of this recommendation exists elsewhere in another working group. So am I hearing then that the group is leaning towards deleting it in this space with the thought that it might be then repetitive? Okay, I'm seeing some heads nodding, so I'm going to go ahead and strike this through. Okay. Then the next recommendation that the group will be scoring via survey here has to do with, it's from the Crossover Youth Working Group. So states some study findings here and then notes that the working group further suggests researching the effect of therapeutic environment on care of youth with higher levels of aggression. And so I think there were a couple of recommendations via survey or a couple of comments via survey that we might consider a language change here. So would give the group a minute to look at that one and then would ask for direction on what language changes we should consider. Specifically, I think a comment made via survey was modifying the recommendation to make it about the community-based services that are made available through Senate Bill 367.
This is Rachel Marsh from the Children's Alliance of Kansas, and I sat on that working group related to the crossover youth. And what I would remember is that there was any long number of recommendations from that working group, and my perception is that the issue is, can we better support crossover youth? And that this was one of about 100 different questions. From the perspective of modernizing the mental health system, I would agree that we need to just look at this from how do we support crossover youth and not particularly doing one narrow study. So I would agree with either or both of the recommendations written in the rationale.
Okay, so this is Carly at KHI. Rachel, let me make sure I'm understanding you correctly there. So are you suggesting that we strike this recommendation, and then whenever we're developing new recommendations, maybe later in today's meeting, considering crossover youth a special population, and making a new, maybe broader recommendation at that point in time?
That would be my recommendation, yes.
Okay. Any discussion from the group on that? Are we okay striking this with the idea that it the recommendation regarding crossover youth should likely be broadened? Okay. Then we will make a note that we address that whenever we're developing new recommendations later in this meeting. Okay, we're getting close. The next recommendation the group scored via survey is to do with PRTF. This is one of the new recommendations that you developed towards the end of your last meeting. And it reads, continue ongoing work to improve care delivery and expand capacity at PRTFs, such as through reduction in the PRTF waitlist and incentivizing reductions in readmissions. So via survey, that was scored for ease of implementation at a 7, potential for high impact as a 5. And then there was a suggestion to modify language to include a focus on successful reintegration and discharge planning. So any discussion from the group on either how this was scored or on, it sounds like making some, expanding the recommendation slightly to also include a focus on reintegration and discharge planning.
This is Kathy Bush from the State Board of Education, and I'm kind of new to the group, so I haven't been privy to the previous conversation. But when you talk about PRTFs and reintegration, if there's schools involved, I think it would be good to make certain that maybe the receiving school is involved in that reintegration process. And if I'm out of line, that's okay, let me know, but thinking from a school standpoint.
Kelly from DCF, and I agree that we should include that into the recommendations.
Well, this is Gary from KDEDS, and I really think that the integration of discharge planning and making sure that those services are available at time of discharge, which would include planning for education and schools, I think is greatly important and should be there. You know, the idea of reductions of the PRTF waitlist is something that KDEDS has worked with significantly on and made some major improvements. I think that we have to be careful there not to consider expanding capacity to a point that makes PRTFs not viable. And that's been the concern that we've had. I think we're getting there, and probably by the end of the year, we'll have the capacity that we need. So I question that part of it.
Sure. So what I'm hearing there is that we want to continue ongoing work to improve care delivery, but we might strike the specific directive to expand capacity with the thought that maybe we'd be at the appropriate capacity in the coming months. Gary, do I hear you correctly there?
That's correct.
Okay, any discussion from the group on that edit?
A different one. What do we mean by incentivizing reduction in readmission? I don't like the idea of if a kid needs to be somewhere, we're going to incentivize not putting him back. I just don't know what that means.
Yeah, this is Gary from KDEDS. Lisa, I had the same concern. I should have mentioned earlier. I don't think we should incentivize. Treatment should be related to the need.
Mm-hmm. Thank you.
So this is Carly at KHI. I'll hear from both of you. Plan to strike that portion. From memory, I think the discussion around this last time was wanting to move away from, there was language in a previous recommendation that had to do with shortening and keeping stays as short as possible, something to that effect. And so the thought was that if stays were of appropriate length, then basically youth would be better set up for success upon leaving, reducing the need for readmissions. But again,
Well,
that's from memory. So if the group wants to make other changes there, those are more than welcome.
this is Gary from KDEDS. I really think that improving the care delivery across the board, so before the PRTF is considered, you know, I mean, we don't want to just improve it in the PRTF. We want to improve care delivery, and PRTF is a piece of that. But if we are able to wrap a kid up with the services before PRTF, a lot of times PRTF is not needed. And if we can wrap them up in services when they leave the PRTF immediately, that helps the readmission rate. So I think we're talking, that's changing it quite a bit, I think, but it is, I don't think the problem, the improving care, it needs to be just in the PRTF. It needs to be in the entire system. So improving the care delivery across the board.
Carly, this is Rachel Marsh again with the Children's Alliance. I agree. It's interesting to watch the evolution of these recommendations over the years from multiple task forces, because I think originally the issue was whether we were appropriately utilizing our PRTF and had an adequate capacity. Additionally, whether we were addressing the needs of the youth who were on the wait list as effectively as possible. I think to change it completely to look at only care delivery is misrepresenting what was originally the concern. The concern is that we're meeting the needs of the youth who've medically been deemed to need PRTF but are not accessing them. I think that's all I can articulate coherently at this moment.
This is Andy Brown with KDEDS. And so Rachel, I'm going to check and see if I'm thinking of this right, but what you're kind of saying is that even though over time we've made a lot of progress on PRTFs, you want to make sure that we include a recommendation that monitors how children are being impacted in terms of their eligibility for PRTFs, admissions, as well as what level of service they're receiving. So we might we might focus in on the ongoing part of this and really just kind of make sure that we understand that this is something we want to keep focus on and not take our foot off the gas on it.
That's exactly right. Thank you, Andy. This is Rachel with the Children's Alliance.
This is Gary from KDEDS. I agree fully. I think that says it much better.
Very good. So this is Carly at KHI. Want to make sure I have all of the key pieces in that helpful discussion there. So we want to monitor ongoing work to improve care delivery at PRTFs to meet the needs of youth for whom PRTF is medically appropriate, such as through, and then I'm hearing still continue to keep the list of particular interests there, such as making sure the PRTF waitlist is no longer than is appropriate, focusing on reintegration. So those wraparound pieces you were describing, Gary, reintegration and discharge planning, thinking about wrapping around the youth as they leave the PRTF setting. Any major pieces from that discussion that we're missing?
I'm comfortable with that.
Okay, and then
I only have one. This is Gary. One more comment. Maybe focusing on reintegration and discharge planning, but maybe we also need to focus on the services before PRTF.
Well, this is Kelly from DCF, wouldn't that be our service array that we mentioned in the?
It could be, yeah. I just don't want us to be thinking only about after.
Okay. This is Carly at KHI, gonna leave this as is with the comment from Kelly about kind of the pre-PRTF services being captured in that service array recommendation that the group previously discussed. We've made some changes to this language though, and I want to make sure it's still scored in a way that the group is comfortable with. So ease of implementation score around 7 and a potential for high impact around 5. Any changes to how that is scored?
This is Rachel Marsh with the Children's Alliance. I would at least throw out one vote to increase the potential for high impact to 7. based on the fact that, in my opinion, if we do this well, it will impact children before they need PRTF and after they leave PRTF. So it would be broader than just the youth in the PRTF, and ultimately reduce PRTF utilization.
This is Gary with KDADS. I can't agree more. Almost wonder if it should be an 8, but again, it may just be my preference. But I think when we look at the broader picture, that we are looking at serving children so that they don't end up in the PRTF. So we, I think it's a very big impact. So I would move that we go to even 8.
Okay, I've made those changes on the screen here. We'll ask for final comments here, and then I'll move us along just only in the interest of time. Okay. Then next recommendation that was scored via survey was again a new recommendation and had to do with how we serve those with co-occurring disorders. And so that reads, invest in community-based intellectual and developmental disability services and training around behavioral health. So ease of implementation, that was scored at a 5. Potential for high impact, that was scored at a 6. Any additions, corrections, or comments on that one? Okay, not hearing any. Take us to our next recommendation, still a new one, having to do with frontline capacity. So the recommendation from the group was to increase capacity of frontline healthcare providers, such as pediatricians or OBGYNs, to identify and provide services to those with behavioral health needs. So ease of implementation, the group scored this as a 5, and potential for high impact, the group scored this as an 8. Any additions, corrections, or edits there? Okay. Then I think this is our last last recommendation related to our previous topic of treatment and recovery, to overview quickly here. And it is a new recommendation related to supported employment. So expand the supported employment program, a program that provides employment services to individuals suffering from a severe mental illness, including those with a mental illness and co-occurring substance disorder. So ease of implementation, this was scored as a 4, and potential for high impact, this was scored as a 5. Any additions, corrections, or edits there?
This is Andy with KDADS, and I would also mark pilot program on ease of implementation. We are doing a 500-person pilot on this project, so that's ongoing with CMS at the moment with Medicaid.
Good. Okay. And then I'll open it up for last comments on any of these treatment and recovery recommendations that we have overviewed here this afternoon. Not hearing any. I will then move our screen share over to the topic of today, which is special populations. Now let me find it on my screen. So first, as with previous topics, asked the group if there were any recommendations from those list of recommendations that had been developed by previous groups. Ask the group if there's any that we should skip as they are addressed elsewhere or not a part of what it would take to modernize the behavioral health system. And via email, the one response that I got was this recommendation here regarding serious injury review that comes from I believe the Child Welfare System Task Force. Yeah, recommending that there be a review process both internally and externally for an immediate and necessary response when a child dies or suffers serious bodily injury after having previous contact with DCF protection and prevention services. Any concern from the group about striking this recommendation from the work of this group? Not hearing any, I'll strike that one. And then take us into our first one for consideration here today. On the screen here, it's another recommendation from the Child Welfare System Task Force having to do with how non-abuse neglect is handled in the state child welfare system, recommending that there be a differential response for newborns and that they be referred to evidence-based services. So the first question for the group is this recommendation part of what it would take to have a modernized behavioral health system in our state?
So this may be a clarifying question, but I mean, are we essentially here talking about setting up like family residential programs for substance use treatment, or what are we looking at here?
Let's see if any working group members want to address that question. If not, I can take a shot at it.
This is Senator Petty. Would this also fall under the child welfare system task, under earlier ones where intense intervention like the ABC program? I mean, would this fall into this same sort of thing with newborns?
This is Rachel Marsh with the Children's Alliance. My recollection is that this this recommendation from the Child Welfare Task Force had to do with the importance of addressing the needs of newborns because they're the most at risk for serious bodily injury in the child welfare system. And so that we wanted to make sure that any newborn who had any indicator of risk would be referred to appropriate services. So I happen to believe that it's relevant. I don't know how easy it is to implement, and I believe it would be potentially highly impactful at about a 6 or 7.
Andy, did that address your questions there?
Yeah, I guess I'm just not familiar with what EBSs we're talking about, but we can do some research on that and figure it out.
Mm-hmm. And then I think too, there's likely, I believe there's implementation steps in that Child Welfare System Task Force report. I would just need to pull them up in order to provide more detailed information. So any discussion from the group, recognize that it's a bit broad without listing specific evidence-based services. Any discussion from the group as to how we would consider ease of implementation here? Alternatively, is this one where we feel like we need more information before we can score this one well?
This is Gary from KHI. I would need more information. I don't know what the current programs would be.
Okay, so well, I'll have us move on then, unless Kelly, you want to weigh in here. I'm trying to see if you're still on the line.
Yes, this is Kelly from DCF. I am still on the line. I don't have a lot to add, but this feels like it should, I mean, there are already programs in place that do this. So I'm just kind of confused.
Mm-hmm. Sure. And this isn't one that we have any update from the agency in that earlier in the crosswalk document either. So I will move us on just in the interest of time, recognizing that in order to have that conversation, well, we need more information. Okay, the next recommendation is from the Governor's Behavioral Health Services Planning Council, their Rural and Frontier Subcommittee. And it is to increase funding for crisis bed for the non-insured and underinsured to fill the gap in rural and frontier areas of the state. So similarly to before, the first key question here is this recommendation a part of what it would take to have a modernized behavioral health system?
Kelly from DCF, I'm wondering if we could also somehow further this recommendation just a little bit to increase, I don't know, funding or access to crisis, but in addition to people who are insured statewide. I don't even think it's a specifically rural or frontier area issue. I mean, of course it is, but I feel like it is statewide. But I'm sure Andy knows more about that than I do.
Yeah, I think it's just through that lens because that's the subcommittee the recommendation came from. But I agree, like we could use more funding for crisis services, both physical locations with beds and also things like respite care for children and mobile crisis.
Okay, heard a couple of things in there. Heard that the group is recognizing this as a need statewide. Andy, you also had a comment here about crisis beds specifically for, I think, youth, as well as mobile.
Mm-hmm.
Okay. Did I miss anything else there? For some reason, I felt like I heard 3.
I think I might have said it 3 different ways, but I mean,
okay.
we need more crisis beds, physical plant. We need more youth respite and emergency services, and then we need more mobile crisis.
Okay.
Across the board.
Yeah.
Carly,
Okay.
this is Rachel with the Children's Alliance. Just to follow up on something Kelly mentioned, I think we could probably strike the non-insured and underinsured because it's just an access to everyone issue. And maybe we would even consider saying increased funding for an access to crisis services and beds.
This is Kelsey from KDHE. I initially agreed with you, Rachel, but I think crisis services really falls into that expansion of the community-based service array that we covered within like the treatment portion of this, where I feel like the difference here is the expansion of crisis beds.
I don't have a strong opinion on how we slice it. I'll defer to the folks from KDADS for sure and DCF on that.
Well, this is Gary from KDADS. I mean, I see both sides of that, but I also think when we're talking mobile crisis, we're not just talking beds. So, I mean, that could be numerous things. It could be beds, but it may not be. But I do see your point, Kelsey, that it intermingles the 2 recommendations.
This is Kelly from DCF, and Kelsey, I agree with you too, of course. But I feel like there's some value in calling out specific our crisis array services. Although they are part of the service array, I do feel like because this needs to be, it's to some degree a little bit subset and could be beneficial to specifically work on crisis service array.
This is Kelsey KDHE. I'm good with that. My other comment would be, since we removed like the rural and frontier areas of the state portion of this, I feel like it's more a treatment thing, not a special population thing.
So this is Carly at KHI. Kelsey, I also want to jump in on that note just to let the group know. So I think this recommendation was sorted into this conversation by KLRD because of that rural and frontier component that was included, and want to specifically flag for the group that the finance and sustainability working group has been kind of assigned a different recommendation from the mental health task force about regional community crisis centers. And that reads, develop regional community crisis centers across the state, including co-located or integrated SUD services. So there's no instruction in there from me. Just wanted to make sure the group is aware that pieces of this recommendation are being addressed by that other group. Again, they might make changes to it, but would ask the group to consider that as their drafting language here.
This is Kelly from DCF. So they were talking specifically about crisis centers across the state. Yeah, I feel like this needs to be a little bit more broad because this is really referring to, in my opinion, crisis service array, which could include, in-home, mobile crisis, facilities, beds, etc.
Okay. So
Gary from KDEDS, I wonder if we need to say something more than statewide. Because, I mean, it is statewide, but we should also be making sure that I like the idea that the rural and frontier was in there, because that is an area that seems to, at least those Kansans do feel like they're missed. I like that. Yeah.
I don't know if that gets to your comment, Gary.
It does make it a little more specific. I mean, some people will say, well, you've got services in northeastern Kansas, but we're wanting to expand that, plus make sure that we're filling that gap.
Okay. So this is Carly at KHI. I'll direct the group then to our ease of implementation column here. Looking for direction on any boxes that I should check to describe this program, or any number that people would like to toss out for our first ease of implementation score.
This is Andy with KDADS. I mean, this is specifically a request for funding, so I would indicate that under the barrier to implementation. And then these are existing programs in various parts of the state, but they're largely only in specific areas, right? So there's a lot of work to do to get something that would be statewide. So overall, I would say the ease of implementation is probably on the lower side, maybe like a 4.
Okay, discussion from the group on that. Okay, not hearing any would then direct the group to the potential for high impact. What boxes would you have me check to describe this recommendation, or what score would you toss out for potential for high impact?
This is Kelly from DCF. I would tick all the boxes, and I would say at least a 9 for high impact.
This is Rachel with the Children's Alliance. I would.
Okay, I think that was agreement I heard there from Rachel. Any other final comments on this recommendation? If not, I'll move us forward. Okay. The next recommendation related to special populations reads, expand the 3-day crisis intervention training across the state for police and first responders concerning veterans in a mental health crisis. So the first question then is this recommendation part of what it would take to have a modernized behavioral health system?
I would say yes, because they're often the first to have contact with people that are experiencing a mental health crisis, whether it's adult or a child.
Lisa, Andy, were you getting ready to speak there?
So this is Andy Brown with KDADS, and I was going to say we just got brand new recommendations from the SMVF subcommittee yesterday that went to the secretary. And so we might want to put a pin in this one and review based on that recommendation or that report.
Are those recommendations something that could be shared, Andy?
Yes. Yes.
Those will be out, and we will get those recommendations out. Again, this is building on something that we already have in place in the state, and I think you're going to see in those new recommendations some very clear directions in which we need to be going with this process. And at the same time, looking at what they've already started just in this year. So we'll get those recommendations out. The secretary did approve the circulation of those, and we'll get those for you.
Yeah, and Carly, you might want to, instead of putting SMVF, just put Governor's Behavioral Health Services Planning Council, the GBHS PC.
Okay, got it. So the note I have for the group is that this is one we're going to circle back on once we know exactly how that recommending body has updated this recommendation. Sound okay?
Yep.
Okay. Next, recommendations from the Governor's Substance Use Disorder Task Force having to do with neonatal abstinence syndrome. And the recommendation is to provide education, screening, intervention, and support to substance using women to reduce the number of infants born substance exposed, while expanding coverage for family planning services, preconception services, and a variety of contraceptives, including long-acting reversible contraceptives. Is this recommendation an important part of what it would take to have a modernized behavioral health system in our state?
This is Rachel Marsh with the Children's Alliance. I'll say definitely yes.
Okay. And if this recommendation is important for modernizing the system, what type of work would this require as far as ease of implementation? What would it take to make this recommendation actionable?
This is Andy with KDADS, and I think you're looking at mostly a program change. And I would probably have to defer to KDHE about cost barriers, but I think there would be strong continuity, and I think you would probably mostly be looking at maybe agency budget development and maybe regulatory process.
This is Carly at KHI. I want to make sure, Kelsey, you have any comments to add there from KDHE?
Kelsey with KDHE. I don't think I have anything to add. I agree it's more of a program change. A lot of like streamlining of services and supports coordination needs to happen.
Very good. And anyone in the group want to toss out an ease of implementation score for us?
I'm thinking maybe a 6 or a 7.
This is Kelsey with KDHE. I agree with that. There's work underway in this area. It just needs to continue.
Okay. Heard a 6 there. If there's not further discussion on that, would it direct the group to the potential for high impact column? How would you have us describe this recommendation's potential for high impact?
It would definitely impact foster care and children. This is Rachel Marsh.
Yeah, I think you could hit the low income box too.
Okay. Anyone interested to toss out a score for potential for high impact?
8.
Okay. Any discussion there? Very good. Then I will move us to our next recommendation. Now, this next recommendation is another one related to neonatal abstinence syndrome from the Governor's SUD Task Force, and it is to provide education on best practices and reduce stigma, promote standardized care regarding NAS cases, including developing a standardized reporting process for NAS cases across the state, and offer universal training and continuing education. And then there's a specific training program recommended in here as well to all Kansas birthing centers. So first, is this recommendation an important part of what it would take to have a modernized behavioral health system?
This is Kelsey with KDHE. I would say yes, but I think it can be combined with the previous recommendation. And it really just the first half of this, the continuing education through the Vaughn training system has already occurred through the Kansas Perinatal Community Collaborative, the KPQC. But the the other, I think, could be included. The training, education, reducing stigma piece could be included here.
Okay, so I'm going to add that up above. Can make the language read more nicely later. Does adding this component above, does that change how we would score anything for this previous recommendation? So we added language to provide education on best practices to reduce stigma and promote standardized care regarding mass, including developing standardized reporting. Okay. Sounds like we're comfortable as is. So I'm gonna strike through this one for us because we've combined it. And then a third recommendation here from the SUD task force related to neonatal abstinence syndrome. This says increase the number and capacity of designated women and family treatment centers across the state. Is this recommendation part of what it would take to have a modernized behavioral health system?
Probably from DCF, yes, I agree.
Okay, heard a couple of yeses in there. So I'd maybe direct us to ease of implementation. How would you have us describe this one in terms of ease of implementation?
This is Kelsey with KHI. I just wanted to add a point for like this group's consideration. In addition to expanding capacity of the treatment centers, it'd be great if we could expand designated women's treatment services for outpatient programs.
Okay, so this is Carly at KHI. I've added a piece into this recommendation that we would be wanting to increase the number and capacity of both women and family treatment centers as well as outpatient treatment programs across the state. With that revised recommendation, how would we score that in terms of ease of implementation?
This is Deb Stidham. I think it challenges that in a little bit. If we're talking about residential women in treatment centers versus outpatient, outpatient's going to be easier. So I guess we're going to average the two.
That approach works as well as any.
So I'll just go easy and say 5.
Okay, and I guess we haven't really described this one in terms of ease of implementation. So any discussion scoring that as a 5, or how would we, what boxes should we check here?
Deb Stidham, I think it's a program expansion since we have those things, wherever you put that.
Okay. Anything else we should add as far as describing the ease of implementation for this recommendation? Okay, not hearing any. What about just, oh, go ahead.
Sorry, Kelsey with KDHE. There might be a system consideration to be made here when you think of like services that are now being made available through DCF with Families First and KDADS with the block grant, making sure that information is streamlined.
Okay. Then would move the group over to the potential for high impact column. How should we describe this recommendation in terms of those considerations? What boxes should I check?
Kelly from DCF, I would say foster care, low income, and children.
Will this recommendation benefit a large population? Or
This is Kelly from
alternatively,
DCF, I would say a 5.
5. Okay, any discussion there?
Deb Stidham, I agree.
Okay. Then we'll maybe move us on to, we'll say this will be the last existing recommendation we'll cover, and then I want to make sure we have plenty of time to develop some new recommendations regarding special populations. So this next recommendation is again related to neonatal abstinence syndrome, and it is regarding medication-assisted treatment during pregnancy. Is this recommendation an important part of what it would take to have a modernized behavioral health system?
This is Deb Stidham. I think this could be rolled back into the one that we already had on Matt.
And to clarify, the other recommendation that we had around care for neonatal abstinence syndrome, or there was another kind of set of recommendations related to medication-assisted treatment as well?
That one, the latter, the broader recommendation around expansion of MAT.
Okay, we'll make that addition unless there are concerns with that approach from the group. Not hearing any. Want to direct the group. There are still, I think, 4 or 5 recommendations left that we'll plan to score via survey, but want to make sure that we have time to kind of zoom out a little bit and think about new recommendations regarding some special populations that should be closely considered in the work of this group. So similarly to some of our past meetings, I'll provide a quick overview of some of the barriers that this group first brainstormed whenever we were thinking about this topic. We came up with a list of barriers that we should be trying to address. So I'll overview those now, but then would welcome discussion of new recommendations really anywhere the group is interested to start. So the first barrier that the group wanted to be sure that we addressed through recommendations was the need to focus on perinatal depressive disorders. Also, the group wanted to focus on access to IDD and mental health services for children outside of foster care. The group noted that another special population might be caregivers, and another special population might be those for whom English is their second language, and specifically it looks like access to workforce development supports there. So first, just looking at those list of barriers from last time around, any new recommendations from the group. And as I was talking there, I also added crossover youth to this list as we discussed earlier in our meeting today. So where should we start here with new recommendations?
This is Gary for KDADS, and I would suggest we start with the IDD and mental health services for children. And I'm not sure that we want to say outside of foster care. If we want to just, I mean, there's a huge gap for IDD and mental health services when that's for children in general, not just outside of foster care. Part of that may be expansion of the IDD waiver services. And workforce.
Or reimbursement rate.
Reimbursement rate.
Access to waiver services, because there are waiver services, just but people will have a hard time accessing them due to either workforce, and the reimbursement rate for the services is not high, so people don't want to provide them. So
the lack of funding makes incredibly long wait list and really makes the services almost just not usable.
Mm-hmm. So I'm hearing increase funding for IDD and mental health services for all children. If you're talking about, do we still want to keep that specific to by expansion of IDD waiver services?
Well, when you think about IDD kids, and we have this conversation all the time, especially if we have an IDD kid that's having behaviors, people want to say it's just mental health and it's not related to IDD issues. And then there's the struggle. Do we put this, does this child get served in the mental health side, or the IDD side? They fall in that huge gap. And if they end up falling on the IDD side, it's more of a crevasse or canyon than a gap. And a lot of that's due to that funding and lack of providers.
So a quick question on that comment there, Gary. Is there a recommendation the group would be interested to make specifically to those youth that fall in the gap, maybe that I heard you describe between IDD services and mental health services?
The dual diagnosis.
This is Clay from DCF. I don't know. It's also just a general IDD issue in general, you know?
Yeah.
I'm hearing maybe it's two separate recommendations, or just the one about IDD services generally. How would the group like to move forward there?
This is Gary from KDEDS, and I think, you know, the mental health services we're doing okay. I'm not going to say fairly well, but we're doing better. The IDD services are certainly a huge problem and a big gap. So I'd be okay with us focusing on the IDD side.
Kelly and I agree, especially since we kind of addressed, you know, mental health service array previously. I would agree just to leave this as
Okay. So if we're planning to address in this recommendation, IDD services specifically, am I hearing then we would strike this highlighted portion there, and it would be about increased funding for IDD for all children by expansion of IDD waiver services and provision of, I'm going to say like workforce supports.
Workforce development, we don't have enough. There's not enough, even if we had the services, we don't have enough people to provide the service.
Okay. Any pieces missing? I know the language is not tidy, but any pieces missing from that new recommendation?
I have a suggestion, you know, on services available to caregivers. Can we put in there caregivers and families? Because, you know, I just have a real concern there, because whatever we do, the family is the first line of defense in what we're doing. And whenever you talk to people that are having problems, you know, families want to assist and help if they have, you know, the knowledge and stuff. They're always looking where can they get services. So I just was looking at that, and I
Sure.
think
This is Gary from KDEDS. I would certainly agree with what Wes is saying there. So many times we have the ability to serve the child, but not the ability to support the parent. So parent supports and services for parents are certainly going to be huge.
So this is Carly at KHI. What recommendation is the group interested to make there? Is there a specific mechanism that the group should point to as the strategy to increase services available to both caregivers and families?
This is Rachel Marsh with the Children's Alliance. One proposal I would have, and I might have to go look at the code number unless Andy or Gary has it, is Medicaid code 90846, which would allow providers of mental health treatment to meet outside of their meeting with children to consult with caregivers and families about how to support their behavioral needs. So we need to access that Medicaid code in Kansas. That would be my, I would have to double check on the number, but you get the point.
You're talking about therapy sessions, family therapy without the child present.
Yes, sorry, I know I'm not very articulate today. Thank you.
That's okay.
Yes, and so this is Carly at KHI. This came up as recently as I think yesterday. And so how this group, how the group yesterday that met handled this, they said enable utilization of procedure code 90846 in Medicaid as a tool to support youth in foster care as well as any child accessing care in a PRTF. So that's how that group is handling that. Is there a different piece of that that this group would like to address, or is it adequately taken care of, I guess, by that draft recommendation from the System Capacity and Transformation Group?
I think this is Gary from KDEDS. I think if they're addressing that particular piece of this, I think that's good. But I do think there's more to this in the sense of parent support, caregiver support. Not just therapy, but whether that's parent peer support or other peer support programs is certainly something.
Okay. So then it would be that as a recommendation might be something around increased access to parent peer support for caregiver, and I'm wanting to preserve that language that we're talking about caregivers and families as Wes has recommended.
Yeah, we want it to be whoever is that that person caring for the child.
Is the group interested to be specific about like the caregiver and family of which youth in the behavioral health system have particular needs?
I feel pretty strongly it should be all youth in the behavioral health system.
Deb Stidham, I agree.
Okay, so have some draft rough language on the screen there. Increase access to parent peer support for caregivers and family of youth in the behavioral health system. Anything missing or off base in that draft language?
This is Gary, no.
Okay. Then would maybe direct the group, we talked earlier today about wanting to be sure we specifically had recommendations that addressed the needs of crossover youth. Any recommendations that the group is interested to make regarding that special population?
This is Rachel Marsh. I might ramble a little bit and then let other people make sense. My recommendation on this issue is that we continue to develop linkages between the behavioral health system and the juvenile justice system and the child welfare system that help us all better understand the differential diagnosis and the differential treatment approaches appropriate for youth who are externalizing their trauma by what looks like juvenile offender behaviors, but may be underlying trauma needs or mental health needs. My perception is that it's an ongoing process that in this population needs to be lifted up for collaboration and coordination between the multiple agencies in the education system probably as well.
Okay, this is Carly at KHI. I was trying to take notes on the screen there as Rachel was talking. I'll reflect that back to you all and see what we have to add there. So something along the lines of a recommendation to continue to develop linkages between the behavioral health system, juvenile justice system, and the child welfare system to increase understanding of treatment options available to youth externalizing trauma in the crossover youth population. What's missing there?
This is Gary from KDEDS. I think we somehow need to make the point that our current services and current treatment options don't necessarily meet this population's need.
This is Deb Stidham. I would agree with that. It's much like the adolescent care across the state, it's a specialized treatment. It's actually, I would even say, a specialized workforce. Some folks aren't cut out working with adults, and same with adolescents. And so this really speaks to the workforce issues as well, in my mind.
It's almost like a developing a specialty kind of service.
This is Carly at KHI. Any other notes from the group on this specific special population?
This is Kelsey with KDHE, not for this specific population, but I wanted to make comment on the perinatal depressive disorder.
Sure.
Sorry, Kat. I would like to see this expanded to perinatal mood and anxiety disorders. That includes both depression, anxiety, psychosis, kind of like anything that happens within the pregnancy or postpartum periods. And I've been thinking on like what this recommendation should be, and I'm still struggling with it a little bit. So definitely there needs to be something around like increasing identification of perinatal mood and anxiety disorders. There is a new Medicaid policy for screening for maternal depression, but it's only for the child's benefit and the child's Medicaid plan as part of the well-child visit. And that policy will not cover any treatment services that comes out of like necessity based off of the screening results. And it can't be billed under the mother's Medicaid plan or anything during pregnancy, which is often when symptoms start to occur. So I think there's opportunity there around some increasing identification, as well as supporting like, again, our frontline providers, which we already have a recommendation around. But there's very few like mental health clinicians who are certified or have any training or expertise in the treatment of perinatal mood and anxiety disorders in Kansas. So I'd like to see some like workforce development strategy around that.
Okay. Kelsey, this is Carly at KHI. I want to make sure I have at least the big buckets correct on the screen here. So we want to work to increase identification of those with perinatal depressive and mood disorders, as well as make sure there are options for care provision for those individuals. In order for that to be possible, what I also heard was this might be a separate recommendation, or maybe part of that is workforce development to ensure there are those able to care for those with perinatal mood disorders. What's missing there, or what corrections would you make?
Just the title of it, perinatal mood and anxiety disorder. Sorry, perinatal mood and anxiety disorder, PMAD for short.
Great. What about others? So handful of other special populations that have come up at different points in time include, we talked about pregnant women there, infants have come up as a special population. Rural and frontier area is a group that we've discussed repeatedly. Veterans is a group that we've discussed kind of in passing. Are there any other recommendations that the group would like to draft while we're on this topic?
I think one that this Deb Stidham jumped out at me is fathers of dependent children, because I don't think that we've focused on that particular group, and I think it's growing. So back to the expansion of the family treatment programs and things to make sure that we're making room for those kinds of alternative arrangements as well.
Okay, Deb was trying to take notes there as you were talking, but adding as a sub bullet to the access for parent peer support, or or kind of general services available to caregivers and family, that there are additionally appropriate supports for fathers of dependent children as well. Anything else I should add to that one?
Well, I was really thinking back upon the recommendations about the expansion of women and children's treatment. That's really where I was thinking about that one. I mean, it works here too, but.
Yeah, this is Gary. I don't know that I'd take it out of there. Gary from KDADS. We could say it's inferred under caregivers, but.
I'll just move that back a level so that it is considered as a component both places. Okay, I might do a last call for comments at this first pass of these new recommendations on this topic. If not, I will provide a few brief administrative updates, but last comments here first.
Carly, this is Rachel Marsh. I don't know how to make this brief, but there are two areas that we haven't discussed that seem to be common themes in my work that relate to mental health. One is the area of domestic violence, and the other is the high risk that children of incarcerated parents face. And so I don't know if we could look into Qualtrics questionnaires related to modernizing the mental health systems from those perspectives, but I think those are two high-risk groups.
Very good. So this is Carly at KHI. I've made note of those populations, and I think I'll take you up on that suggestion, Rachel. We might have those as open fields in a Qualtrics response to see if there's any specific recommendations that anyone would like to throw out in that space, and then we would address it at the start of our next meeting. Does that sound okay?
That's wonderful. Thank you.
Okay. So in our final 2 minutes here, I just wanted to quickly update the group on, I think, 3 administrative items. So first, look for a Qualtrics survey from me where we will briefly score the remainder of the recommendations related to our special populations topic today, as well as scoring some of those new recommendations we just drafted. So keep an eye out for that Qualtrics survey. Also, I think you saw this briefly in an email from me, but as we were putting together work for the telehealth topic, as a reminder, telehealth was a topic that was assigned to all 3 working groups. We realized we were going to have a lot of overlap among the supplemental experts who were asked to weigh in on those meetings. So the decision's been made to pull out a subgroup to meet on telehealth with members from each of the 3 working groups. So my first question is anyone on this group interested to join that subgroup conversation on telehealth? And we expect them to meet the week of November 9th. I'm seeing a hand up from Lisa Southern and Rennie McKinney as well. And also, Gary, seeing that hand now too. If others are interested after you've had a moment to think about it, feel free to just send me an email. You should have received a doodle scheduling poll from me. So if you participated in that, I'll consider that an indication of your interest as well, and I'll include you on that invite when it gets scheduled. It's 1:30, so I think the last update item that I have for the group is just the reminder that the special committee, the full special committee, will be meeting again on October 30th. Similarly to our last special committee meeting, I expect there will be report outs from the working group on filling the special committee in on the discussions that have happened in this space. Additionally, expect the special committee to have discussion around the idea of, what is our vision for a modernized mental health or modernized behavioral health system. So please please come prepared to weigh in on that, as well as we'll talk about it specific to each of the topics that each of the groups have taken up. Any questions from anyone before we adjourn today? All right, not hearing any. Look for more information from me via email, that Qualtrics survey, and other items. But if there's nothing else, we will adjourn. Thanks so much, everyone.